Hello and welcome to our More Skin Deep Anatomy series. In the 7th installment, we shall be covering the anatomy of the kidneys. In this episode, we shall be covering the surface anatomy of the kidneys, the fascial layers surrounding the kidneys, followed by the blood supply and nervous supply. Just a quick disclaimer that Medsoc accepts no liability for any inaccuracies in the video, and students are encouraged to double check with their course material. Lastly, any images seen in this presentation are either original or have been referenced at the end. Let's take a look at the learning objectives. Firstly, we will recall the basic neurovascular and gross anatomy of the kidneys, understand the pain progression of kidney stones, and lastly, the treatment and diagnosis of kidney stones. Let's examine the case. This is Mr. Johnson. He is a 36-year-old male, and he was awoken by sudden onset left flank pain. He is admitted to the A&E department, and when asked about the pain, he describes that the pain has migrated to his lower left quadrant, left groin, and left testicle. The patient describes the pain as 11 out of 10, with 10 being the worst. The doctor performs an abdominal examination and finds that there is no guarding or other peritoneal signs. There is no palpable mass, and there is a normal abdominal aortic pressure. Lastly, a KUD study is done, an X-ray, and the findings are that there is a left renal calculi with mild hydronephrosis. Now let's take a closer look at the anatomy. Let's explore the surface anatomy. Firstly, this is a PA view, meaning a posterior to anterior view. Normally, there are two kidneys present in the human body, this being the right kidney and the left kidney. Commonly, sitting superior to both kidneys are the adrenal glands. As you can see in this diagram, there are two white structures which sit above the kidneys, and these are the 11th and 12th rib. It is important to note that the kidneys sit between the vertebral levels of T12 to L3. And this is what it looks like on a human body. You will notice that the right kidney is slightly inferior when compared to the left kidney, and this is because there is the liver which sits superior to the right kidney. Descending from the kidneys are the ureters, which are present bilaterally. They drain into the bladder, which either stores the urine or releases it during micturition, and this is done via the urethra. Now we shall explore the fascial layers which surround the kidney. Firstly, here is your kidney, and it is surrounded by the renal capsule. Anterior to this structure is the Ureters fascia. Posteriorly, the fascia is known as the Zacca-Candles fascia, and laterally they fuse to form the lateral conal fascia. Any fat that is located between Ureters fascia and Zacca-Candles fascia is known as perirenal fat. Any fat outside these structures are known as the pararenal fat. Anterior to all these structures, there's the parietal peritoneum. Commonly, the kidney is known as a retroperitoneal. Commonly, the kidney is referred to as a retroperitoneal structure. This means that it is an organ which is covered anteriorly by the peritoneum only. The most posterior layer of fascia is known as the transversalis fascia. You will notice that there is a lot of space in between the parietal peritoneum and Ureters fascia. This is referred to as the anterior perirenal space. Similarly, the space between transversalis fascia and Zacca-Candles fascia is known as the posterior perirenal space. I would like to highlight to you the importance of knowing the fascia, and in particular Ureters fascia. This is because Ureters fascia acts to fix the kidney in the retroperitoneal space. But more importantly, in cases of renal cell carcinoma, it is used in TNM classification. Now let's take a look at the cross-section of the kidney. Firstly, here is the renal capsule which surrounds the kidney. The kidney can be subdivided into two layers, the cortex and the medulla. Within the medullary layer, you have what is called the medullary pyramids. The pyramids open into the minor calices. The junction between the pyramid and the minor calyx is known as the renal papilla. Moving on, the minor calyx drains into the major calyx, and finally, the renal pelvis. The renal pelvis is continuous with the ureter. A common site for a kidney stone to be lodged is at the uretero-pelvic junction, here. We shall now take a look at the macrovascular supply of the kidneys. Each kidney is supplied by a renal artery. This is also accompanied by a corresponding renal vein. These large vessels will then eventually continue as the segmental arteries and veins, which will then later on branch into the interlobar arteries and veins. As the interlobar arteries and veins reach around the edges of the medullary pyramid, they are known as the arcuate arteries and veins. Finally, these will finalize as the interlobular arteries and veins. Here is a diagram which simplifies the microvascular supply of the kidneys. Moving on, here is the macrovascular supply. Firstly, let's orientate ourselves. Here are the kidneys. There are always two, bilaterally, a right and a left kidney. Moving on, you have your ureters, which descend inferiorly from the kidneys, and bilaterally you also have the adrenal glands. The major vessel which provides the arterial blood supply of the abdomen is known as the abdominal aorta. Inferiorly, it continues as the right common iliac artery in this diagram, which will then bifurcate into the external iliac artery and internal iliac artery. Notice that these are also paired with corresponding veins, and these veins originate from the inferior vena cava. It is important to note that prior to the abdominal aorta bifurcating into the right and left common iliac, you have three major branches. These are the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Inferior to the superior mesenteric artery, you have the right and left renal arteries. These are also accompanied by the corresponding renal veins, and moving down from the renal arteries, you have the right and left gonadal arteries. Gonadal here referring to the uterine artery in females or the testicular artery in males. An important analogy to recall the position of the ureters relative to the vessels is known as the water under the bridge analogy. Basically, at the pelvic inlet in females, the ureter runs inferior to the uterine artery, however in males, the ureter runs inferior to the vas deferens. Although the right and left gonadal arteries originate from the abdominal aorta, the same cannot be said for the left and right gonadal veins. The right gonadal vein originates from the inferior vena cava, however the left gonadal vein originates directly from the left renal vein. The same can be applied for the suprarenal veins, which are the veins which drain blood from the adrenal glands. So for the left suprarenal vein, it drains directly from the renal vein, whereas the right suprarenal vein drains directly from the inferior vena cava. Now let's take a look at the nervous supply of the ureters. It is important to recall that the upper section of the ureter is supplied by the spinal nerves from T10 to T11, the middle section by the spinal nerves from T12, and finally the inferior section by L1 to L2. The preganglionic nerve for T10 to 11 is known as the lesser splanchnic nerve. This nerve synapses in the aortical renal ganglion. For T12, it is the least splanchnic nerve. It itself synapses in the renal plexus. Finally, for L1 to L2, the nerve is known as the lumbar splanchnic nerve, and it synapses in the inferior mesenteric ganglion. Now let's return to the case. Firstly, the condition. It has been diagnosed that there is a renal calculi obstructing the ureters, and this has led to mild hydronephrosis. How does this occur? Well, firstly, the ureter gets progressively narrower the more inferior you move. Therefore, there is a higher chance of occlusion the further down the kidney stone moves. This obstruction will cause a back pressure leading to hydronephrosis. Hydronephrosis is the enlargement of the renal pelvis and calyces. Now let's move on to the signs and symptoms. Firstly, the patient presented a loin to groin distribution of pain. This is because, if you recall, the ureter's sensory innervation is from the spinal levels of T10 to L2. If you observe the dermatome map on the left, you'll notice that these dermatome levels of T10 to L2 give the exact distribution of pain the patient will experience if the kidney stone were to move down the ureter. Secondly, the patient reported the pain to be very acute, rating the pain as 11 out of 10, with 10 being the worst. More interestingly, the patient had no peritoneal signs upon examination, such as guarding. This is because the kidneys are a retroperitoneal structure, hence when they are inflamed, the pain is visceral first, rather than parietal. Lastly, the patient doesn't vomit but feels nauseated. Now let's move on to the diagnosis and treatment. Diagnosis was done via imaging techniques. Firstly, a KUB study is done, which stands for a plain kidney, ureter and bladder study, followed by a spiral CT scan of the abdomen and pelvis. Treatment is twofold. Firstly, to treat the hydronephrosis, a bladder catheter can be installed. However, to treat the renal calculi itself, commonly, lithotripsy is performed, where shock waves are used to reduce the size of the renal calculi. This will ease the passing of the kidney stones for the patient. Now let's recap the importance of anatomy. Firstly, recall that there are three key sites that a kidney stone could be lodged in the ureter. These are the uretero-pelvic junction, where the ureter meets the renal pelvis. Secondly is where the ureter crosses the iliac vessels. And lastly, there is the uretero-vesical junction. This is where the ureter meets the bladder posteriorly. Also recall that kidney stones tend to have a loin to groin distribution of pain. This is because the ureter's sensory innervation is provided by the spinal nerves from T10 to L2. Lastly, recall that the treatment of kidney stones often involves the use of lithotripsy. This is a method where shock waves are used to break up the kidney stones into smaller fragments, which will ease passing. These are the references for all the images you have seen in this presentation. Please check out the handout for this tutorial in the description below. It's got a summary of what we've talked about, along with some extra information and some questions to help with revision. If you enjoyed the tutorial, remember to like the video and subscribe to our channel. If you want to see more like this, then check out our YouTube playlist or visit our website at uobsurgsoc.com. Thank you!